So our next session is Tearless, Disability Transitions, Childhood to Adolescence to Adulthood, and we're very lucky. Before I talk about it, I have to make sure I acknowledge our sponsors for this event. We've thanks to Monash University School of Public Health and Preventative Medicine and the AusCAP network, and I wonder if a lot of people know about the AusCAP network. It's actually a fantastic resource. It's free. That's really about reproductive health. There's so much information there, so I really encourage people to engage with that. So we're lucky enough today to have Rob Ward and Dr. Rick Wong and Evelyn Culnane for our session. Rob Ward is a full-time GP working for the last 27 years in a group practice in Geelong. He has a 26-year-old son with a disability, and I really think so inspired by the people who have lived experiences and share them. I think it's so powerful. He's on the board of Gateways Support Services, which provides support to people with significant intellectual disability. He's a current GP facilitator for the PHN Echo series on disability, and he's also part of the SPIDER project reference group supporting people with intellectual disability across healthcare. And I agree, continually amazed by what he learns from his patients, and he's frequently frustrated with the inadequacies that he's in systems designed to support people with intellectual disability. So thank you so much, Rob, for coming today. Thank you.
Thanks. Thanks very much, Anne. So the session today is about disability in children, and if you think about, there's such a wide range of disability in children, from the mild to the profound, from those physical, intellectual, behavioural, social, such a huge variety. And there's also such a huge diversity in the families and societies from which they come, from their educational, their language, their cultural backgrounds, of the families these people are growing up with. And there's a big variety in the GP skill set out there about how comfortable we feel looking after children with disability. But there is one thing that all of them have in common. In fact, there's two things all these children with disabilities have in common. That one day, most of them will become adults with disability and enter the adult system. And that's a given. And the other given is that they will all need a really good GP to continue their transition through to living wholesome, full lives to the best of their ability. So today we decided that our presentation should be on that transition process, which involves us all as GPs, all in primary healthcare. So I think I'm going to be joined today, hopefully if all the technology works, with Dr. Rick Wong, who's a GP, and Rick's there, and Evelyn Culnane, who's the transition manager at the Royal Children's Hospital, and they're going to join us a little bit later to discuss a case that they've been working on to really sort of demonstrate the transition process in someone with quite complex needs. So if we can just go to my next slide. So I thought this was an interesting quote because it came up on the ABC recently, and it's from a 30-year-old with cerebral palsy. She says, "When you're a child, you're in the child's health system. You're completely wrapped in support. I had a physio, a paediatrician, an orthopaedic surgeon, an OT, a speech pathologist, and everyone was working together for my best of healthcare. Then I turned 18, and it was literally like falling off a cliff." So today's session is about what we can do as GPs to make that transition process more successful for our patients. So what changes when you hit 18? Well, the system changes. The child and adolescent health system is often holistic, it's often goal-orientated, it's a multidisciplinary team approach, it's collaborative, everyone chats together. There's a regular review, you have your 6-monthly review with your paediatrician. Everything's arranged. As a parent, I know I really look forward to those reviews with my son. It was just something, nothing happened and it didn't change anything, but it was such a welcome review just to have someone there. And there's a team approach. Often these kids are in a special school and are surrounded by a collaborative team that work together. And for significant disability, there's also a lot of other specialists involved in that developmental thing. And then you hit the adult health system, And it's literally fairly self-directed. So you've got lots of organisations coming up to you and say, well, how can we help you? You say, well, I don't know. You know, I was given that all beforehand. So it's often self-directed from the patient. It's often disease-focused. You lose your specialist. Suddenly at 18, your paediatrician's not seeing you anymore. And so you've lost that. So you've lost that coordination. Your care becomes quite fragmented and less coordinated. We often talk about the care being in silos and not communicating with each other. So the transition at 18, just a few thoughts about it. It's often totally arbitrary, and some of the issues people have is with their care is not because of their medical condition has changed. They haven't hit some biological milestone. It's a totally arbitrary event, and it's often just created by the system that we've created for them as healthcare professionals in the healthcare community. Suddenly at 18, that just is a cut-off for some reason, that all the things that have been constructed for you when you were a child are no longer there. The other thing about the transition, it's totally predictable. You've got 18 years that you know this is going to happen. It's not something that's come out of the blue. And it's very plannable. So I think with some pre-planning, some pre-thoughts, you can make the transition earlier. And I often think of the analogy of doing my tax. It sort of comes up to you at the end of the year and you just wish you'd done all that planning beforehand, because when you really get to the point where you know it's coming, it just comes and you haven't prepared anything, and it all becomes a lot harder. So what I wanted to do today is just to share with you my thoughts about some habits that we could develop when we're looking after our paediatric patients. And they're habits that can maybe improve your connection with your paediatric patients. They're habits that make you feel a little bit more in control when the consultations feel totally out of control and overwhelming. And it can improve outcomes for our patients, and probably give us some professionally rewarding interactions to make sure we make us feel like we're doing a difference. And habits that, if we can focus on them in the paediatric years, can make transition into adulthood a little bit easier. So I'm just going to go through these quickly. I think just being there, identifying yourself as the child's GP and just owning the role, and say that is a really important role, and it will become a really important role as they get into adulthood. And if it's not you, then maybe suggest to someone that it could be someone else, or point that patient in the direction that you should be seeing your regular GP. You know, don't see me for the referral to the paediatrician, see your regular GP. That's their role. And being honest, if you're the right person to continue with this patient, you know, if you're about to retire, then maybe they need to make a connection with a younger GP who can go on the whole life journey with them. So get involved early, be proactive. I think being really curious about your patient's disability, doing some reading about their syndrome, you know, log on for some CPD points, do some reading, it's really easy. Ask lots of questions, and learn from your patient and learn from their families. Because when they hit 18, you may not be able to ask the paediatrician anymore. You know, you've only got to a certain point where you can't ask those questions anymore. Use all opportunities, like when you're giving a flu shot, when you're writing a referral, to connect with that patient, to learn more about them. Learn who else is involved and what their goals are, and encourage an annual assessment. This is not a habit that's just for the GP to say an annual health assessment, but it's also important for the patient to get used to, I need an annual health assessment as I enter my adulthood and throughout life, because we know that that's a really important aspect for people with a disability. I think documenting the patient's health journey and writing really great notes. I'm sure we've all looked after people in adulthood with a disability, and you've got no idea where the diagnosis comes from, and there's no historical documents. You know, you can't access the paediatrician's notes at the time. So I think a GP, if you're in that point of time, whether you're going to be looking after them for a long time or a short time, your notes should be really good at that time. Why medications were started, why they were stopped, why a diagnosis was made, and notes that you can then transfer to the next GP or to the next practice that the patient joins, because it is a total life journey, and these are really the basis of the notes that are going to continue with the patient for their life. And they should tell a story through all the stages the patient goes through. Work collaboratively with the team. Show the paediatrician that you're really interested. Maybe when you write your referral, show that you've measured them, so you've done their height, you've done their weight, you've actually had an interest about which OT they're seeing and where they are in school. Not just a please can you continue to see. You need to demonstrate that you're the person that's going to take over their care. You're the apprentice, really, who's going to take over their care at 18 and make the paediatrician feel confident that you can do that. Ask for some correspondence. Ask for some correspondence from the allied health. Learn the language the allied health people are using, because it can help you ask better questions later on and help you look after other patients that you're seeing. When the time comes, be ready. Make sure you've got all that information, because you can't really go back and get it. And I think as the build-up, also make sure your patient's ready, because they may not realise that at 18 everything changes. They've been very happy at the specialist school and with everything, and then all of a sudden they graduate from that and there's nothing for them. So make sure they're ready as well. And make sure you've thought through any potential problems that they might have and seek a solution together. I think listening to your patient and those supporting them is really important. I mean, they'll have a lot of knowledge, but also remember, this is the first time they've gone through it. You know, they're not experts. You hopefully have gone through this process a number of times and know the problems. Beware of the other stuff that's going on, certainly within families. You know, finishing school is a big thing. New service providers. Siblings are often transitioning into adulthood as well, so from a family dynamic point of view, it is huge. Have they been able to access new services? Make sure they're hooked into the services they require. Finally, knowing all this, I think the more we learn, the more we're aware of the system failure, and I think don't accept the system as being anywhere acceptable, looking after people, adults with a disability. There are still huge challenges, and there's significant unmet needs and gaps in the system. And there's significant inequity in delivering healthcare to people with a disability. So I think it's our job as GPs to become a bit of an advocate and to identify those things. I think the more you are involved, the more you are able to identify and advocate for better healthcare in the future. So there's my list, and I hope as we go through with Evelyn and Rick, we might better sort of think about those habits that we can all get into to make the transition process easier for our patients. So I'd like to introduce Evelyn and Rick there. Hi, guys.
Hi.
So I'm going to hand over to Evelyn. Evelyn's the the manager of transition services at the Royal Children's Hospital, and she's been involved with the SPIDER project with the West Vic PHN, and her extensive knowledge and experience with transition with people with complex needs through the Royal Children's. And I think she's been collaborating with Rick, and we're going to present a case study today, hopefully to illustrate some of the features with regard to transition. So thanks, Evelyn and Rick.
Thank you, Rob, and thanks for setting the scene and doing such a great job to set the scene for our case study today. It's a real pleasure for Rick and I to share this case with you. So thank you very much for having us. So Rick, if you wouldn't mind progressing to the next slide. So this is just a terrific diagram, I think, which encapsulates everything that Rob had just mentioned earlier. The RACP in 2014 put out a statement around best practice for transition of young people with complex and chronic disability needs. And essentially, we do need to prepare our patients and families early within the system. There needs to be a period of conjoint care and collaboration as prior to that transfer point. And the transition needs to continue well into the adult services. So there's a group at the University of New South Wales, Julian Troller, who's done some terrific work for many, many years around the transition of patients with intellectual disability and disability more generally. But he says young people with ID experience very high rates of mental ill health, particularly during the period of transition. During this time, young people with ID and their carers have high support needs. And in the transfer from child to adult-oriented care, these needs are frequently left unmet. That's certainly the case, and it really helps to set the scene for our case study today as well. So thank you. A group in WA also conducted a study to look at how involved GPs were during that transition period. And as you can see here, the study revealed that very few GPs were actually involved during that transition from paediatric to adult care for their patients that they were continuing care for. Most GPs actually cited lack of communication between various health services to GPs, and there was certainly inadequate collaboration that existed. The transfer of information is always an interesting one, and when we're talking about different sectors, different institutions, health services having their own discrete information databases, the transfer of information is actually critical to the ongoing care of a young person and the family. So this is a resource that we developed for GPs, actually for families and patients to use with their GPs and their paediatricians to actually aid that communication between providers, healthcare providers, and with the notion that patients and families were central to that communication and it be patient-held. So really championing and empowering patients and families to hold this document, to encourage that communication, that engagement with their GPs and paediatricians jointly. So just a couple of publications that we've published in recent years around the transition model of care, which we entitle Tearless Transition, really looking at how we can make that transition as smooth as possible through conjoint collaborations, consistent assessments of not only the severity of the mental health issues, but also family needs and supervision needs for the family. So it's multifactorial. There are lots of different aspects to consider when we transition a young person with complex needs such as these. But this publication helps to highlight some of the things that we have commenced working on at the Children's. And I put a little health pathways banner down at the bottom of the slide to indicate that there is a GP health pathway that we developed and co-developed to aid GPs in the management of this group of patients. Thank you, Rick.
Terrific. Thanks, Evelyn. Thanks, Rob. And thank you very much for having us present this very important case, which illustrates the difficulties of transferring care of a child with complex needs and also a family with complex needs as well. So our patient is SB. He was born on the 3rd of July 2003. She was monoclonic pregnancy, complicated by twin-to-twin transfusion syndrome, and delivered at 30 weeks by caesarean section for severe IUGR. SB's birth weight was 700 grams. Her co-twin birth weight was 1400. She had a quite stormy perinatal course with 5 days of ventilation and phototherapy for jaundice, and spent 75 days in the neonatal intensive care, and was discharged at term plus 5 days, corrected for gestational age. And her development up to about the 18-month stage was probably commensurate with those dates. So she had a few words by 18 months, was interactive, had quite normal motor milestones. But by the age of just after 18 months, her parents noted that she'd become less responsive to them. Her speech seemed to be curtailed, and she was less interactive with her sister and other people in her life. So she was still under the care of a developmental follow-up clinic at the Mercy Hospital for Women, and she was referred for speech therapy and OT. And at the same time, her co-twin was showing normal development. At the age of 3.5, she was under the care of a private paediatrician and was formally diagnosed on the autism spectrum. Her score was 43 of a child autism rating scale. There was no unifying underlying diagnosis, and she continued with early intervention. By the age of 5, her behaviour had become quite significantly disruptive. She was subject to frequent tantrums and meltdowns. This terrible self-injury where she would actually strike her head and other parts of her body. I'd often see her and she'd be bruised and swollen, and it was terribly distressing for her and her family. She was also striking out at others, which was a major behavioural issue to manage. And by the age of 7, she commenced intensive ABA therapy, which is applied behavioural analysis to try and address some of her disruptive behaviours. And by that stage, she'd also become virtually non-verbal. I'll just show you a picture of my clinical assistant. This is my staffy, Lexi, who is often in my consulting room. And one of the interesting parts of SB's behaviour was that she actually became verbal when she came in and saw my dog. She would just say dog or make some other sort of verbal mutterings, I guess, at best. But it was interesting that would elicit that sort of response, but otherwise she was completely non-verbal. So at the age of 11, C was referred by a paediatrician to a psychologist, and she was actually diagnosed with generalised anxiety disorder. She was commenced on fluoxetine and Risperdal at night because her nights were becoming very, very disturbed. And unfortunately, to this day, she might often sleep only 2 or 3 hours through the night, and the parents will take it in turns to be with her. Also, by this stage, she did require 24-hour care, which was supported by the NDIS. By the age of 13, she was mostly housebound, double incontinent. She had chronic constipation and, look, I'd call it urinary hold-up, where her mother could tell that she was holding off and she might only urinate once a day, a high volume. Her periods were managed with continuous oral contraceptive pill, and her behaviour was still very, very distressing and ongoing self-injury, so much so that the parents actually had her at one stage in a gridiron helmet to stop her striking her head and face so much, but in the end she just ended up injuring her hands. It's just very, very difficult. Her dad works as a full-time mechanic in a Porsche workshop. Mum was a full-time carer, and they had good care provided through the NDIS, but no real other extended family supports. At the age of 15, she was assessed by the psychiatry team at the Royal Children's, commenced on olanzapine and desvelin vaccine, and also referred to Irabina services. They have a severe behaviour program, again, which is funded by NDIS, because I think the cost without NDIS funding is well in excess of $100,000. By the age of 17, having been on olanzapine, SB had significant weight gain and worsening constipation due to a combination of a diet. She's extremely fussy with her food, and so unfortunately her diet was quite poor. She had constipation also from the anticholinergic burden of her medication, and she had 8 presentations over 7 months to the Children's Hospital in acute urinary retention, which required catheterisation under intranasal sedation. In 2021, her mother was diagnosed with a locally invasive breast cancer and was found to be BRCA1 positive. So she's undergone bilateral mastectomy and oophorectomy, chemotherapy and radiotherapy as well. So it's just when you think, how much more can a family take? And then in 2022, the co-twin, who also was diagnosed with diabetes, type 1 diabetes at the age of about 15, presented to Austin Emergency in acute Andersonian crisis, and so is now on ongoing lifelong treatment for adrenal failure.
So thank you, Rick. And this is the point where SB was referred to me at the Royal Children's. So in the context of SB having an external paediatrician to the Children's, no real care coordination within the healthcare system of the Royal Children's, but a fabulous GP in Rick. And then therein lay the need for us to think about providing some scaffolding for this family, not only with regards to the transition to adult health services, but how we were going to manage that. The challenge also lay in engaging with the family where SB had very, very high care needs, barely slept through the night with 2 or 3 hours sleep. The family barely functioned, and they were very honest about barely functioning. Sustaining for SB's father to sustain work was a challenge. So this is the context in which we received a referral for SB to think about how we were going to engage with the family. So that was the first point. Determining who her current care teams were and at that stage, and who they needed to be in future, what services were available out there to care for her and to provide that safety net for the family and for SB. Establishing engagement and links with those services. So therein lay the process of communication, engagement with external services to work out the best plan. And we needed to bring the family on board with this plan as well, and that was critical to the success of the plan. We set up several multidisciplinary transition case conferences, including engaging with not only Rick, but various specialists across the Children's Hospital, general medicine at the Austin, and looking at building links with mental health and overall care providers, including the Centre for Developmental Disability Health. We drew in the external paediatrician, the private paediatrician, into this forum, and the emergency physician, department physician at the acute hospital site. So we needed to bring everyone together and had held several meetings with the patient and family present at all of these meetings. We needed to establish links, most importantly for the family, provide them with their key contacts, understand whose role it was to do various, to care for various functions of SB's care. We had access at the time to, and it was all complicated by having to transition SB during COVID. So, and I'm sure Rick will talk a little bit more about that later. We were fortunate to have some engagement from disability liaison officers at the acute hospital site too, which provided that overarching disability support, was able to manage and put in place some care plans to manage some of the behavioural needs that SB had within that setting. Thank you, Rick. And certainly, going back to the previous slide, Rick, it took a lot of work to orchestrate and coordinate this care, and without a central point of communication and coordination, it would have been virtually impossible to transition a young woman like SB across to adult services. And so the first consultation at the Austin occurred in 2022 when SB was 19 years of age. However, that also occurred in the context of family counselling appointments for various reasons, but that also complicated the transition and firming up that plan at the adult site. Thanks, Rick.
Thanks, Evelyn. So, yes, certainly the transition period was just marked with a lot of ongoing instability, with 5 presentations between February and May 2022 to the Children's ED, again in retention requiring catheterisation. So in May 2022, SB was admitted to Royal Children's Urology for a trial of Botox injection to the urinary sphincter to try and address her recurrent episodes of retention, which failed. And so SB was admitted for a suprapubic catheter insertion. but then arrangements were very definitely made for her ongoing catheter care to be transferred to Austin Urology. And up till present, and unfortunately, I think as we speak, SB is an inpatient at the Austin. Now she has issues with recurrent urosepsis. She often pulls on the suprapubic catheter, so she's got hematuria. It's difficult to tell, and then becomes distressed and gets a fever, and she's grown all sorts of typical hospital bugs: Klebsiella, Pseudomonas, Enterococcus faecalis. She's had multiple broad spectrum antibiotic courses, including Cipro, and she's had 3 admissions with pseudomembranous colitis, and had to be treated with vancomycin. At the moment, at home, mum manages her urinary symptoms with gentamicin bladder washouts, and it's just becomes very tricky when she starts becoming distressed and self-abusing, that whether she's got a UTI or whatever, and it's become quite difficult. But having said that, infectious diseases unit at the Austin have been quite good in giving us a bit of guidance about how best to manage SB. But yeah, she clearly has some ongoing complex care needs. But the transition has been done, and so her care is shared amongst general medicine, infectious diseases, urology, psychiatry, and the chronic pain team as well. And I think she'll also come under the care of a rehab unit as well, to try and get some consistent care and good communication between the various stakeholders. So it's interesting, when I spoke to SB's mother about the challenges that she perceived, certainly accessing the ED has been majorly problematic for her. And according to her, she said there was no action plan established. Now, I've since found out that certainly this has not been exactly the case. I think plans were put into place, but just through the very chaotic life circumstances that the family face, I think probably some meetings that were scheduled were cancelled, or the parents just couldn't attend. So I think that's a work in progress. And certainly, speaking to mum recently, I think this situation has improved. But it's just very difficult for someone who's got just severe sensory needs to sit in a waiting room just with other adults and the general public. So, look, it sounds like her transit through ED is about as good as can be expected, and I think the family is aware that every step was taken to try and expedite that process. Look, a big problem with transition to adult services is the fact that often a parent or a caregiver can't be admitted, and this was certainly a huge issue during the COVID pandemic, where restricted visitor numbers, etc. But certainly, when SB had been an inpatient at the Children's, her mother or father was always with her, and I think this has been a major challenge for the family. And yes, certainly, just the capacity for acute adult medicine to deal with the very complex care needs of a patient who's severely affected on the autism spectrum it's been extremely challenging for them as well. And certainly as a child, SB's mother's got lots of photos of me holding my stethoscope or an otoscope or a tongue depressor, and used to show them to SB before coming down, so that SB will be aware of what's going to happen. And obviously this just couldn't happen in terms of SB being able to be familiarised with the adult hospital during the times of COVID. So yeah, that was extremely challenging for the family. And look, when you've got multiple units looking after the patient, of course, there's going to be some issues with communication. There's been some, I guess, differences of opinion between especially urology and the ID people in terms of the management of SB's recurrent urosepsis. And look, I think it's just an evolving situation. I just attended another multidisciplinary meeting with C and her parents and Gen Med, ID, urology, and yeah, certainly steps have been taken to improve that situation. But I think it's always going to happen. It's a perfect storm and in acute situations. But yeah, we're certainly persevering with that, and I think things have definitely improved in that regard.
So just to sum up, the collaboration that exists between primary care, the Austin and various services in the community continues, as Rick mentioned before, and that certainly helps. We've certainly found that providing that communication network, although not always ideal in a system that is essentially disparate in acute hospital services. However, having a home team that is Rick combined with general medicine was really helpful for SB. And having a centralised, coordinated and communicative approach was certainly the best means of achieving a successful transition in this case.
So, look, I speak with SB's mother probably 2 or 3 times a week, and I think she's quite appreciative of what's happened in the transition in terms of the scaffolding for the family. Both the mother and father were at this meeting in person. I joined on Zoom, and look, I think that they're doing their very best to communicate well with the family, and more than anything, just for SB's parents to feel that they are heard and that their concerns are taken seriously, and strategies put in place to best manage SB. But as I alluded to earlier, you can put all these things in place, but when you're dealing with the human factor, it's difficult, and and things will go pear-shaped, or SB will present to the ED when it's absolutely flat out. Well, I don't know when it's never flat out, but and things will happen and things slip through the cracks. But we just need to, I guess, just have safety nets in place. And I've got the Austin micro biology lab on speed dial on my phone, so I'm always calling them up to check on the urine culture results, etc. So look, we do our very best, but it's certainly a significant part of the burden of care does fall to the primary caregiver, and I'm very happy to continue to play a role in this. But certainly it's been so important for us to have good collaborative structures with the tertiary hospital. Thank you very much.
Well, I think I'm sure you've read Rob's book, Rick. I'm curious where I can buy that book. I know. But I think it'll be a good one. But yeah, what a powerful case, and I think for me, just hearing those stories, just the powerful role a good GP can play. But sounds like, Rick, you've done that in spades. So we've got 5 minutes time for any questions. Yeah. Plenty of time. I don't know if we've got a microphone anywhere. You might. No, we don't have a microphone. You can call it out and I'll say it so the online team can hear. Can you speak loudly?
I myself, I work as a community nurse in Melbourne for a community health center. So I actually, it's both a comment and a question really. So the thing is, I believe many of us have been at the front of, have been working in a system where we actually have the heart of wanting to care for people with disabilities and people who are very affected by, like, as what was...
Hang on, just stop, because I think this is too long for me to remember. Sorry.
Oh, no, that's okay. All good.
Well, I'm going to say it's, what's your name?
Oh, David.
David, who is a community health nurse, and he's
Yes.
going to tell us a little about his own experience.
Yeah.
So we need a question.
Oh, yeah, it's a question. Yeah,
Yes,
really.
please.
Yeah. So I guess I am very conscious of time as well. I just wanted to ask, so with having, been dealing with like the NDIS system, how do we then try and centralize the focus on helping more people, like the case study that was presented? Because obviously this is one of the few cases that there's an excellent wraparound service around helping people with such complex disabilities. And I myself work with people with complex care needs in the community, and it only seems that with the amount of resources that we have and being trained in this field, we are struggling sometimes with the amount of people that we have to care for. So I guess is there like a broader strategy that we can look at to tackle this problem?
I think it's a question around what's the best way to get the resources we need. Is that what you're... Yeah. I don't know, Rob? Rob? Rob, will you be able to speak to that?
Or any participant. Yeah. So
the question is how to access the most amount of resource, whether it's NDIS. It's hard to get services, and any tips?
I'd probably say that it is really hard to access services, and so that's, as a general practitioner, it's important for us to advocate. I've heard it said once the best option for young children with an intellectual disability or with disability is to have rich parents who are engaged with their care, because that's, and as parents, I think we are really involved in our kids' care, and it's often difficult to know where to go from that. I think it's also important not to lose that health history as people go through, because this patient could easily end up living in a disability care home, lose contact with her parents, lose contact with all those past histories. And so I applaud Rick. What a wonderful history, Rick, that you've created there. And that's going to be a legacy for this patient to be able to see where she came from. Because it's not, because she'll be a 30-year-old in a care home looked after by people who have no idea about where she came from. Rick's going to retire one day, or move, or she will move to a care home some other further distance away from Rick. And so those, that initial GP, real involvement in those early years is going to be really important to continue her and advocate for her. And the things that Rick will be able to point, when she goes to the emergency department, and that story that he will be able to summarise will aid her health and her health journey for the rest of her life. Rick, can I ask a question of Rick? Rick, with all the work you're doing, how does the Medicare system support you, or is it all just a labour of love?
Oh, it's a love job. I mean, we've been having medical students in our practice for, well, I've been there for nearly 30 years. And we've got one GP out of it. And I don't think it's because we're terrible. I think they just see what we do and say, why would you do that for that sort of meagre income? And so, no, it's an absolute love job. And I've just accepted that. I don't think Medicare will sort of be, the changes will come in that are required in my working life.
And if we could change the Medicare system to actually remunerate GPs like Rick or people with a special interest in that, because looking after people with disability it's not sexy, it's not a business model, it is purely a labour of love, and you can do as many care plans and annual health assessments and try to tweak the Medicare system as much as you like, but it's not a business model. I mean, it's not like setting up a skin clinic where you can just generate some income somehow. It is a labour of love, and I really applaud Rick and the way he's gone through that journey with his patient, because that's going to be a great asset for her moving forward.
It's very involving just to see the other trials of, ESB's sister with Addison's and diabetes and mum with breast cancer, and we haven't even asked the question yet about BRCA status in these kids. So, look, and I must say that I have a daughter who's an actor, so I'll be working forever. So, lucky for them.
We've got time for one more question.
One more question. Tim.
It seems to be there's a fairly clear divide between what happens under 18 and what happens over 18, and that's a health system problem, isn't it? So how do we sort the health system out so that we can learn from the paediatric era to transform into the hospital system? The Austin's a very interesting hospital because they have one medical record, electronic medical record, and as I understand it cost them $500 million to do that, but they did it. Barwon Health, I think, has 29 different systems at last count. We're clearly talking about silos here. So the question is, how does the PHN, how do sort of bodies sort of come in and help to change the system so that the paediatric system can work in the community, not just the hospital system?
I guess the question is, where do you advocate? You know, these sort of system, we were talking about that with Sandro, we can see the deficiencies, but it's quite hard to even know where to advocate, isn't it? I think, but I don't know if you've got any idea. I don't know. No. Well,
and I've got one, a question here on behalf of the online audience. Lots of love coming through on the chat for, especially for Rick and Rob, for the amazing job that they do. So one of the online attendees has said that it's truly difficult to coordinate MDT, especially on transition patients like this. Is Health Pathways sufficient to provide guidelines for such complicated cases, or do we need a care coordinator with hospital linkages?
I could probably speak to that, if that's okay. We do have systems within hospitals, and we do have disability liaison officers within hospitals, and I suppose the premise behind engaging with a home team like general medicine in the acute hospital system in adults allows us to have essentially a care coordinator or a care team in conjunction with a great GP and the various other specialists that need to be involved in that young person's care. So everything works best when you do have a central point of communication and coordination. It's about identifying who that will be, and having that close collaboration well prior to transfer, and having a GP, for example, such as Rick, to really pull it all together at all points of the transition, and then post-transition is absolutely essential.
I'm going to vote for Rick and Rob for an Order of Australia. I don't know about anyone else. It's time now. So I'm just going to close. Thank you so much for really powerful presentations.